Okay, so yes, I am a dermatology nurse practitioner. I started working in this field when Ronald Reagan was president. So I've been doing this a lot of years and really fell in love with this disease because there was so little to offer these folks, and I was the director of the Baylor Psoriasis Center, and patients were being disfigured. Their lives were truly tormented by this disease, and it's become has been my favorite thing to do or see in the clinic. So I'm just going to try to give you a bit of a walkthrough on how we assess psoriasis, and all the photos that are in my presentation are all from patients that I've seen, and most of them ones that I've seen within the last few months. So that will give you a bit of an overview. So first question. Because I get this question from when rheumatologists send patients to our clinic and say, I think they could have psoriatic arthritis, but I'm not really certain if they have psoriasis. Can you find any on them? So these are my questions. Or ask them to take off their clothes. That's probably more appropriate.
All right. Well, we got a lot of very thorough people participating today. 80% do a total body skin check, focusing on high-value areas. 18% look at elbows, scalp, and knees. If negative for rash, document no psoriasis. And 3% document suspected, and document no psoriasis noted. So a lot of people doing a lot of looking.
Okay, I wish y'all could get dermatologists to do that. That would be awesome, because it's remarkable how many people come into the clinic and we ask to do a total body skin check. Even when we're looking for cancer, for skin cancer, they often will say, I've never been looked at head to toe. So it seems obvious to me. It's kind of like I always think of it as a cardiologist only listening to one chamber of the heart, as opposed to kind of doing the whole thing. I feel like we have to. Okay, there you go. So the other thing that's interesting about psoriasis patients that will come into your clinic is just to find out what they know. And I have to throw this up here, and I put this in your pre-work. Just, if you haven't looked, sometime just look and see where patients are getting their information. Dr. Oz has this whole thing about putting if you have psoriasis on your feet. Have y'all seen that, where you put it in one of those tubs, the pedicure things, and let the little fish come and eat the excess scales off? Yeah, it's truly on there. So it's really fun to find out and there's a tremendously high dissatisfaction with in dermatologic care when people have psoriatic disease. I'm confident you are doing a better job than we are. So the assessment tools, we really don't use assessment tools in the derm clinics the way you do, tools and surveys and things like that. It's more of how much do you have, where do you have it, and are we confident that's what you've got. And there's been a big push. Everybody says that you will know severe psoriasis when you see it. That's easy. And then most of the time we kind of know what mild is, but we aren't good at defining moderate. And so there's a big push to have sort of a dichotomous definition that you have it or not, and then if you do have it, can you get management with just minimal treatment such as topical therapies, and if not, then you need to move on to other categories. So we do look at body surface area. We do sort of a global assessment. Sometimes it's just, are you well controlled, or is it bothering you, is it affecting your quality of life? But there are tools available, but mostly those are used in looking in clinical trials. So this is just to help you see what a mild amount of psoriasis can be if you're looking strictly at body surface area. With this guy who those are pustules on his hands, and you can see how it's destroying his nails. That's going to be 1% body surface area, which is the totality of the palm. But clearly, that is going to have a significant quality of life impact. So you can't just say that has mild disease. And this young lady, same thing, 1% body surface area. And as you know, we do have some therapies that are FDA approved for use in as little as 1% body surface area, if that includes the genital area or the perianal area. So again, assessing disease and trying to figure out, am I going to call this mild, moderate, or severe, is very much based on what the patient tells you, and then also how you would classify it. So the areas that you're commonly going to see it. One of my pet peeves is when someone has diagnosed a person's psoriasis and just walked in and saying, "What are you here for?" And the patient sticks their elbows up and says, "I have psoriasis." They give them some ointment, send them out the door. The average derm clinic appointment is 7 minutes. So that person has to present what skin they want looked at, figure out what it is, what you're going to do about it, and move on. But if you're not looking at all those areas and asking those questions, in the most common areas that I look, the first thing I'm going to do if a rheumatologist sends a patient to the clinic is really dig throughout the whole scalp area, look in behind the ears, ask about genital area, and if they'll let me, look at those areas, particularly the gluteal cleft, all around their belly button, umbilicus, looking through their nails, fingers and toes. Knees and elbows, yes, we see it there all the time, but there are a lot of other rashes that show up on knees and elbows, and it can throw you off. The lower back, and then, of course, palms and soles. We look at psoriasis, we use the induration, erythema, and scale, and that's how we rate it in clinical trials as well. And the most frequent complaints of symptoms, when I started training in the late 80s, got into this field, I was told psoriasis didn't itch, and I would try to tell my patients that. Eczema itched, psoriasis didn't. But when a survey was actually done about 15, 18 years ago and asked people what their top complaints were, itch and pain rose to the top. So I had to rephrase my thoughts about what this disease does to people. And they also have difficulty articulating what that pain or discomfort is. They'll describe it as tingling, burning, stinging, but there is definitely sensation there. It's not just a visual situation. And still to this day, I have patients who will come in to the clinic and have been told by some dermatologist somewhere that this is a cosmetic disease. So the other things that you want to find out just in history when you're trying to determine if they do have psoriatic disease or skin, have you ever had a rash, even if it's not there at present, because it can wax and wane. It can wax and wane from a year or less out to, there was one survey that showed as much as 54 years between episodes. So have you ever had a rash? Did you ever have strep throat as a child and develop a rash? Do you think you have heavy dandruff? Because oftentimes that's the way they'll describe it. Do you have itchy genitalia? It's usually scrotal area for men and the vulvar area for women, and then of course perianal itching. And then you ask about abnormal nails. They almost always think that they have fungal infections in their nails or have had some sort of trauma. And if you do nail cultures in psoriatic nails, a lot of times it's going to be positive for fungus because it's just an opportunistic infection that's there in those damaged nails. Then the other things are asking about the family history. A lot of times they will say, yes, my grandmother had horrible nails, or we had really bad eczema in the family. They don't know the difference. They really, really don't. And then facial rash. Facial rash is incredibly common in childhood onset psoriatic disease, and they will think it's just seborrhea or have a different name for it. Because again, they've been getting their information off of social media sites as to what the disease should look like. And then we are always digging around for other immune-mediated disease. Do they or family members have, rheumatoid arthritis, Crohn's disease? And I'm sure you've asked those questions as well. Okay, so this is a gentleman that showed up in the clinic about 2 weeks ago, and he had been a clinical trial patient with us. And, they disappeared for a period of time. We got him on compassionate care. He was doing really well. Like everyone else, decided that he probably should stop treating because of the coronavirus that was going around, and of course his psoriasis blows up. And so this is a great example of that silvery scale, fairly well demarcated, and he was starting to have edema. He was literally starting to swell because of his skin being so eruptive and so incredibly itchy, and he was very, very miserable. Then these are other patients with presentations of psoriasis that don't look as typical as what I just showed you with that other gentleman with severe disease. This African-American lady, she has lymphedema with a lot of very hyperkeratotic, thickening skin. She has acanthosis nigricans, where that velvety texture in people with insulin resistance. You'll see that everywhere the skin folds, but the plaques are definitely evident in the on her back. This person in the middle has psoriasis as well, and it just doesn't look as typical because they've been trimming off a lot of the excess plaque around their foot, and they did not even know that that's what they had when they had a couple of other little spots, and we started digging and looking and said, oh, well, you know, that's going to be the same thing. And then this is a younger person that has facial psoriasis, and again, did not even realize that that's what it was. Just had a couple of other small plaque areas in different places, but we're looking for that silvery scale and being very well demarcated. We know that there are a lot of triggers, and the reason that matters, I'll show you some situations that have come into clinic in the last few weeks where things have triggered disease and made them erupt a lot more in people that have otherwise been stable. The amount of drug-induced psoriasis is really, maybe I'm more aware of it, I don't know, but it just seems like it's never ending. And then stressors, physical, emotional stressors. I've had people this year that have always been clear, 10, 15 years I've taken care of them. They haven't been difficult to keep under control, but this year it's a struggle. First thing I always ask is, are you taking your medicine? Have you stopped taking your medicine? Has there been any interruption in care? The age of onset in skin is 28, which means that I'm going to see their joint disease, if they're going to get it, begin to show up in their mid to late 30s statistically. You can see it at any age. I've only seen a few cases of infant psoriasis, but we do see it in childhood. But most of the time, there's a bimodal prevalence, which usually is when they hit the onslaught of puberty. You'll see an eruption develop and then again you'll see it as they sort of go through a postmenopausal period. Geriatrics, not as common, and it's pretty uncommon to see it. And usually if I have an older person come in, I think they have psoriasis, that is one of the cases where I will biopsy, because most of the time you can figure it out without it. This guy came in just a few weeks ago, and the GI doctor is a pal. He works in the building, and he texted me and said, this guy has been so sick. I put him on infliximab, and now he's got a horrible rash. Please tell me I didn't give him psoriasis. And he had literally lost 40 pounds and it was new onset Crohn's. He had never really had problems until the last decade, and we had to biopsy him, and sure enough, it was psoriasis eruption. Those brown spots on his back, those are just keratoses. Those are nothing. This young lady was doing great in clinical trials, completely clear. She decided to go on a float trip back in the summer, went down to the Comal River in central Texas, and got sunburned, and this is what's called the Kebner phenomenon. So this is a trigger sensation, not by drug, but because of trauma to the skin. And she was doing beautifully, and we had to completely change her medicine because the biologic she was on, once it lets this happen, I couldn't get it to go away without completely altering her medication. This gentleman is a genius. He is a sort of a nano medicine technology physicist. He's unbelievable. And he has just started immunotherapy for his lung cancer, and this erupted within a matter of 10 days. And had to do a biopsies on him, and it was proven that this was a psoriasiform reaction. So you can see it again. Drug eruptions are common. This was a rheumatologist sent this patient over. This man had kids at home. He was doing great. He was on adalimumab, and then all of this happened. He had never had more than 1% body surface area of psoriasis, and this erupted. But we quickly knew that something had changed. Why was he breaking out? And it was that his kids had been sick. He did not realize that was positive for strep. Sometimes they're symptomatic, sometimes they're not. We treated him, of course, with antibiotics, and ended up having to change his medication to etanercept, and he's been clear. This was about Christmas before last, and he's been doing beautifully ever since, and I hardly ever see him anymore. Another drug onset eruption, and this young lady from Central Texas, and she was very thin and didn't have any high risk factors for hidradenitis. She didn't smoke, none of that, but she had been on adalimumab and was then doing pretty well. And with several months with being on adalimumab, suddenly she just broke out with this severe, scaly, painful rash on the scalp. All of her hair started falling out, and she came up to see us, and of course it was psoriasis that was induced by the adalimumab. So it definitely happens. I didn't hear you talking about apremilast much this morning, but I always show this because in dermatology people are convinced that apremilast is safer than some of the biologics, and I'm not sure where they get that bit of information, and I always want them to know that you can have a reaction to any one of the medications. All the medicines work for some people, yet there's no medicine that works for all the people. And this particular gentleman we started him on apremilast because he wanted an oral agent, wanted to get away from something injectable, wasn't sure if it would work, but he had a lot of itching. He had significant palmar and plantar plaque psoriasis, so I thought it's worth a try. And boy, within a month, he blew up, was rashy. I'm not sure if you can see his scalp, but you can see pustular type eruptions happening with his scalp. And then the pustules would become scaly, and the erythema that he had. And he's another guy that I had to biopsy because I wasn't sure if this was drug eruption or psoriasis, and come to find out it was actually both. So he had a drug rash to the apremilast, and then, of course, it kebnerized into psoriasis. So, and I still see him. And then this is what erythrodermic psoriasis can look like. This is a young woman, and sad to say, I literally got the phone call yesterday from her mother that she had passed away. She was struggled with alcohol abuse and was young, much younger than I am. And her disease would get significant. You could be on the same medicine, her disease would clear significantly when she had her alcoholism well managed, and when she didn't, when she started drinking a lot, it would do this. So that's why lifestyle changes can make such a huge difference. This is a drug-induced case. It looks so incredibly small, but this person was biopsied, sent to us, because it came back as psoriasis, and there were only a few plaques, but it's incredibly itchy. And the lady said, "Yeah, do something. I want it gone." And we looked at her medication list and thought, why is this geriatric woman, getting new onset psoriasis that just keeps erupting and is so itchy? And just had her get off her beta blocker, and it just went away. So sometimes simple things can make a difference. So I told you before that the skin disease, especially if you are seeing them and if they're on some sort of treatment for psoriatic arthritis, most everything y'all do improves the skin. And looking at the last gentleman's presentation, in the 23s, IL-23s can be very, very effective in skin, but I have patients that just don't do as well with their joints when they're on the IL-23s as they do with TNF inhibitors or the IL-17s. And that's always an issue when you can get skin clear but not joints, or vice versa, and trying to figure out how you're going to manage that. And it can naturally just come and go, get better. And I hate to just jump from one medication to the next. It takes a lot of work. It takes a lot of work on the staff. But anybody whose disease is just a struggle and they're having those symptoms, they're having disease that's popping up in other places, either more body surface area or multiple types that are showing up all at once. And also with the presentation, just also looks different by age, it looks different by race, it looks different based on what their lifestyle choices are. Again, the smoking, drinking, weight-related thing can make a big difference. And I'm really thinking about the quality of life impact affecting people with as little as 1% body surface area. Another very classic looking psoriasis, and you can see how in this young girl's knee, how you have that central clearing, you have that annular plaque all around the scalp, elbows. So that's a very classic one. If I showed you a picture of her that we took of her a year ago or the year before, the child is literally doubled in size. She's gaining weight so rapidly that I think she's going to have a lifelong problem with psoriasis, psoriatic disease, and of course, all of the comorbidities associated. So let me show you this and let you decide which one of these is guttate psoriasis. So there you go. I think you can see all the different.
Okay, people a little slower to vote on this one. I think you stumped them, Melanie, but here we go. 80, 90, up above 100. There we go. 47% say B, 27% D, 13% say C, 8% E, 5% F.
Okay, so D is definitely guttate psoriasis, those small little plaques. C is a young girl that every time she gets pregnant, she develops horrible pustular psoriasis, horrible. Her first onset was 15 or 16 years of age with an unplanned pregnancy, and then again in her 20s. F, you can clearly see that very large plaque, and if you look at her right heel in the Achilles area, you can see why she hobbled in. When I watched her walk in, she clearly has psoriatic arthritis onset or enthesitis. E is a Kebnerized small plaque psoriasis in a guy. The top tattoo did not bother him, but when he got additions in the second tattoo, he Kebnerized in it. A is plaque. So B is hives. Actually, that was thrown into a bit of a trickery. Yeah, so that's urticaria. It does look just like guttate psoriasis. So if there was scale, but hives will come and go, it will look different every day when they wake up, and that was the only way that you would know the difference. If you'd had the background information on that, you would have probably been able to tell it. So guttate is the one type of psoriasis that's the most likely to go into remission. And it's usually exacerbated by some sort of infection. And it could be strep. I've seen it be from syphilis. I've seen it be from a lot of other things. Here's some other cases. So this is really the patients that come into your clinic. You think they have psoriatic arthritis. You think that you probably are convinced that they have had or currently have some sort of psoriasis. This is what you want to look at. The guy in the top would... A lot of times that person would be told that he had seborrhea, and he had horrible psoriatic arthritis. And when we got his psoriasis under control and his psoriatic arthritis under control, all of this went away. So definitely look in creases. If you really, really look, you'll see a little patch right here, and you can see a little patch. Okay, it's not showing up, but just right in the bowl of her ear. And this lady right above me, little bitty patch. Same right here, little bitty patch in the bottom with the lady of the ear. Enough to just a couple of other little small signs that we could say that this person had psoriasis. The guy in the bottom on the left over here, I'm going to show you another picture that this guy presented with this and something else at the same time. I'll show you in a minute. And this person, he had a little bit of disease where you could see this really, really scaly hyperkeratotic plaque. But when you push down the socks, a lot of times on men, that's where their psoriasis will be hanging out. It's in the lower extremities, it's under the shin, so keep that in mind. So there are some definitely quite a few differentials of things that are going to look very similar to psoriasis. And these are all patients who have psoriasis that have other things. So one more warning, everything that you see that's pink and scaly, don't assume that it's just psoriasis, because this lady, these spots on her left were not going away. And so you start thinking, why aren't they going away when everything else is going away? They look pink and scaly, it looks like psoriasis, but guess what? Whoops, back, there we go. That actually turned out to be superficial basal cells. All of those pink scaly patches were. This person in the middle, I've had a few of these that had been putting topical therapies on, and it had even been told that those patches were psoriasis because they had psoriasis, and so they were putting topical steroids on, also basal cell. The guy on the right with psoriasis, thinking that these patches on his face were not responding to therapy and that we needed to change therapy. And we kind of took the clothes off, looked all over to see what's going on. Clearly, this man, those were all actinic keratosis. So those are all skin cancers or precancerous pink scaly lesions and not just psoriasis. So the guy in the middle is the same. He had that. And he had that patch on his lower leg, the younger guy, that you could just see this little bit of an annular plaque down by his socks. And he, of course, had it since he was mostly clear, but every time he gets the least bit sick, his psoriasis will break through. And he had been putting his topical steroid on this patch too. Well, it was actually tinea, so the steroid was feeding the psoriasis and making it worse. And then this one over on the left. Does anybody have a good idea of what that might be? Very smart. Yeah, string of pearls. Yeah, exactly. Granuloma annulare. So it'll look very, very similar, and these are all in psoriasis patients. This one on the far right-hand side, you can see mycosis fungoides or cutaneous T-cell lymphoma and psoriasis together in the same patient, but not very commonly. Usually, it's misdiagnosed in the beginning as psoriasis, and then you try some, either if you don't biopsy it, but you try some psoriasis therapies and it doesn't get better, then you always should biopsy and figure out what the heck's going on. And when we relied on phototherapy a lot, it was great because it would make either one of them go away. But that's what this one actually turned out to be. A lot of times along the hips is where you'll see those plaques develop. And these are other cases where people had been told that it was psoriasis, that it was not. The gentleman, this is pemphigus vulgaris on his scalp. He has it on his face. It looks just like psoriasis except for the ulcerations that develop. And then this other lady, she just was a chronic scratcher and picker and rubber, and had used everything from a hairbrush to things that you scrub pots and pans with to try to control the itch, and it caused all that hyperkeratotic look. These also were patients that thought to be psoriasis. The man on the left, if you had not taken his shirt off, you would have thought that he probably had erythrodermic psoriasis, or you think he could have Sézary or some other eruption. But when we took his shirt off, you saw these well-demarcated lines, and we quickly figured out that this was a man who was on hydrochlorothiazide, and the sun was causing him to have this photoreactive dermatoses, and that was not what's going on. This man in the middle had been treated by a couple of other dermatologists in town for psoriasis, and his biopsies were very non-definitive, and it turned out, and nothing was working on him, nothing. Every therapy that had been tried, this erythroderma turned out to be, he ended up having a Merkel cell carcinoma that we found, so it was a paraneoplastic condition that had caused that. And then these two people on the right also having erythroderma, particularly, these are all in geriatric patients, and an internist had sent her over and said, I think she has psoriasis, but it wasn't. It was related to some of the homeopathic things that she was doing. So I think this is my last slide. And, really related to some of the overlap between psoriasis and eczema. And you're going to see more and more of that. And a lot of times, you can take any patch on your body and scratch at it long enough and give it eczema. It would be called an irritant eczema. Or you put the wrong things on it. You put on enough Neosporin or topical Benadryl cream or essential oils, which won Allergen of the Year by the American Contact Dermatitis Society recently. When people talk about essential oils, I'm like, yeah, I keep doing it. I've got a kid I got to get through graduate school, so y'all just keep on using it because it's going to help me stay busy. And, you can cause eczema by using those sorts of things. And there a lot of times when you biopsy, I saw Dr. Cockrell here this morning, and you'll send all the information over to him and say, you got any idea? It's kind of straddling the fence, I'm not sure. And sometimes he can give me some information that says it looks like more one thing or the other, but sometimes it's even difficult for them to tell histologically. So this is, again, some other types of situations that will come up that even the most skilled eye in dermatology that would have atypical presentations where you're going to have pathology. So if you biopsy, if you're not sure biopsy, send it to us. We'll be glad to biopsy if we're not confident either. It's not standard of care, though, just to start biopsying every little plaque or patch that comes through the door. Most of the time you can kind of figure it out without having to go through this. So I believe that's the end of my presentation, and we're going to do questions later, right? Okay, great.